అయిపోయింది. అయిపోయింది అసలు చేస్తారా? Okay, hello everyone. Can you see me, everyone? Yeah, so I'm going to talk to you about gastrointestinal tract. Let me introduce you, everyone, who I am. I'm Dr. Krishna Divya. I have done my MBBS in GSL Medical College and MD Pathology in NRI Medical College, and also DMD from CMC Bangalore. So I'm going to give you an overview of the esophagus. Firstly, whenever the patient comes with esophageal, he'll complain something to you. So I'm going to tell you what are the complaints of the patients complaining with the esophagus. Then you have to understand certain concepts of the topography, of the anomalies, and which will cause the esophageal pathologies finally. So I'll give you an overview of the histology, which is a basis that at the cellular level, what can you know regarding the pathology of the esophagus. Then the muscular disorders, including the syndromes, which all the syndromes can be given as questions for you. And then the pathology, that is inflammatory lesions, esophagitis, GERD, that is a gastroesophageal reflux disease, Barrett's esophagus, varices, and the tumors. So coming to the chief complaints. The chief complaints are usually dysphagia or adenophagia, that is difficulty in swallowing and pain in swallowing, then halitosis. Halitosis is bad breath, and then regurgitation. Regurgitation, you must have experienced a lot of you eating the oily food at different places in the hotels. Like, you know, the food comes back into your throat, and then the heartburn. The heartburn usually is seen in the epigastric region as gastritis, and also the gastritis may lead to the acid, which can cause reflux, and then there will be the heartburn. The clopus sensation, that is feeling a mass inside your throat or at the region of the esophagus, when the chest pain. So coming to the embryology, why you have to know the embryology is that you will have to figure out all the lesions, what can occur congenitally and what predisposes to the acquired lesions of the esophagus. So coming to the esophagus, now we have a common foregut tube here. So the esophagus arises from the cranial portion of the common foregut tube. Usually the trachea and the esophagus separate by the 7th week of the gestation, and these buds arise about 4th week of gestation. So if this is not properly formed, this esophagus tube is not properly formed, then it will cause a little bit of congenital anomalies and distress to the newborn. So this is about the embryology. And coming to the histology, as you know, there will be an epithelium, that's the mucosa, the submucosa, the muscularis propria, and the adventitia. Unlike the other layers of the other places of other organs which are lined by the serosal layer also, here we will not find the serosal layer. Now coming to the mucosa, it is lined by the stratified squamous epithelium, and the submucosa will have the mucus glands. And then here you can see the junctional mucosa. The esophagus extends into the fundus of the stomach. So wherein you will have the squamocolumnar junction, that is the junctional mucosa. So the muscularis propria is also made of inner circular coat and also the longitudinal coat. So here you see, this is stratified squamous epithelium below pavio. This is the lamina propria. This is the muscularis propria. And this is submucosa. Here you can see the mucosal glands. And then this is the inner circular layer and the outer longitudinal layer. There is this distinction about the esophagus that the upper 2/3 contains the stratified squamous epithelium, which will help in the propulsion of the food. And then the lower 1/3 consists of the smooth muscle layer. So remember, the upper 2/3, the muscle layer is different, and the lower 2/3, lower 1/3, the muscle layer is different. Right? So this is the hyperview. So this is a mucosa. This is stratified squamous epithelium, the lamina propria, the muscularis mucosa, and the submucosa with the mucosal glands, and then this circular layer and the longitudinal layer. Right? So coming to the topography. The esophagus extends about C5, C6 level to the T12 level, and it passes through the diaphragmatic hiatus into the fundus of the stomach. Okay. And coming to the parts of the esophagus. The parts of the esophagus are divided as a cervical part, wherein it starts from the oropharynx to the substernal notch, and from the thoracic part, that is, which starts from the suprasternal notch to the diaphragmatic hiatus, and the abdominal part of the esophagus, which is present from the diaphragmatic hiatus to the fundus of the stomach. So there are three parts, that is cervical, thoracic, and the abdominal part. See, this cervical part is usually related to the cricopharyngeus muscle. Okay, this is one the next slide I'll be teaching about the constriction. So just look at this carefully, that there are three parts of the esophagus wherein the blood supply is also different. The cervical part, inferior thyroid artery supplies it, and then the thoracic part is supplied. The thoracic artery, abdominal part is supplied by the left gastric artery. You also know that there are vagus, the left vagus and the right vagus nerve passing right and left side of the esophagus, and then they form the esophageal plexus. The thoracic duct is posterior and then to the left of the esophagus. Just I'm reminding you the basics of the anatomy so that you will know why the lesions will occur and where. So these are the constrictions. Here you see the incisors. You know, when we eat something, there's the oral cavity, and then the oral cavity will produce amylase enzyme, and then your food goes into the throat. Then here, there are some anatomical constrictions and physiological constrictions. Okay, the anatomical constrictions are, this is the cricothyroid cartilage encircling the cricopharyngeus muscle and the cricothyroid cartilage. You have to be cautious about, like, you know, the trachea is encircled by this, and this is the area where the esophagus is having a constriction. The second constriction is at the bifurcation of the trachea, okay, and where the arch of aorta arises. So you can see the trachea is anterior to the esophagus, and then the arch of aorta is anterior initially, then the thoracic artery runs behind the esophagus. Okay, so the third constriction is a lower esophageal sphincter. So we have three anatomical constrictions. One is a cricoid. The second one is the bifurcation of the trachea at the T4, T5 level, that is about the sternal angle, and the lower esophagus sphincter, that is about the T10 level. Okay, these constrictions are the anatomical constrictions, and there are some functional constrictions also. That is, the first functional constriction is the same as the first anatomical constriction. That is the cricoid, or the cricopharyngeus muscle, which holds the esophagus, and then it has a constriction here, and then the lower esophageal sphincter. Okay, so we have related this in the physiological constriction. Okay, so these two are important because the lower esophageal sphincter prevents the acid and the food back into the esophagus. Then this is important because it prevents the air entry into the esophagus when we are taking the food. So these are the constrictions which you need to know, because the physiological constrictions may be the potential site where the you try to put a gastrostomy tube to look out for any lesions in the esophagus, and then you will not be able to put through. It may be difficult if there is a stenosis or a growth or something, usually at the constriction area. So with the idea of having knowledge about these constrictions, it will help us to know where we have to be cautious, right? And then the stenosis may occur, strictures may occur, and the foreign bodies may occur in these constriction areas. Okay, so what are the anomalies? Now you know about the anatomy, histology, and the topography of the esophagus. Now what are the anomalies that can occur congenitally? Agenesis. Agenesis is about absent esophagus. Duplication of esophagus, that is, two tubes are present instead of one. Then mechanical obstruction. Okay, stenosis. It can be congenital or acquired. So congenital stenosis is very, very rare, and then the acquired stenosis may be occurring because of intake of cautious agents, which are chemicals, acids, and all of that. And it may be due to prolonged inflammation also. So what happens when there is stenosis? We call it stenosis when there is the fibrosis of the mucosal layers, and then it will constrict the esophageal tube, and then the food what we take doesn't go inside, right? Then there can be atresia. It can be a congenital lesion. The atresia can be found just as the newborn is born, because if there is a thin tube, you try to feed the baby cannot ingest the milk what you have given, and there will be difficulty in breathing because it may be related to the respiratory tract. So what is atresia? Atresia is thin non-canalized cord, replaced a segment of the esophagus. So here you can see this is the trachea, this is the esophagus, this is the thin non-canalized esophageal tube. This atresia is usually associated with the tracheoesophageal fistula, that is the this part of esophagus ends blindly, and then the distal part is attached to the trachea. So usually the atresia is associated with the tracheoesophageal fistula. Okay. The only thing we can do is about surgical correction, and nothing can be done. Cyanosis, difficulty in breathing, all these things can occur in children. Okay, now coming to tracheoesophageal fistula in detail, I've already told you proximal end ends blindly and the distal end arises from the trachea. So what happens? Inside the womb, there can be swallowed amniotic fluid, the abdominal distension, the air in the stomach, and obviously the food regurgitates out of the mouth, and chemical pneumonia because of the aspiration. So usually you have to remember certain syndromes. These are important for your PG or whatever MCQs. So this is a Vater syndrome, which can be associated. If you are thinking about the congenital anomalies in esophagus, then you have to remember the Vater syndrome. That's the vertebral abnormalities. Anal atresia, I told you, is non-canalized tube, and the tracheoesophageal fistula, renal disease, and absent radius. Okay. Then coming to the esophageal diverticulum, I told you the constrictions in esophagus are important. So whenever there is a weakness in the muscle which is constricting that area of the esophagus, then what happens is there is an outpouching. The outpouching can be true, false, right? So what is a true outpouching? So diverticulum is nothing but the outpouching of the part of the esophagus. It can be segmental. So what is a true diverticulum is that it is lined by all the layers, that is epithelium to the adventitia. Everything is out of the way. Then false or pulsion diverticulum is that weakness in the underlying muscle wall, and then only the mucosa and submucosa are out. So that's how it is different. So you remember a heart or something, you remember the true aneurysm or the false aneurysm. In the true aneurysm, you find all the layers out. It's the same thing, the true diverticulum, all the layers are out, right? Then coming to the Zenker's diverticulum, it is at the area of cricopharyngeus C5, C6 level, where the cricopharyngeus muscle is weakened, and then the part of the esophagus is coming out. So the mucosa and submucosa are out. Now, clinical findings, what you see, when something is there, you find a global sensation, obviously, because of the outpouching, and then the painful swallowing and halitosis because there is entrapped food, and then diverticulitis because of the inflammation which happens because of the food present there. Now, coming to the muscular disorders or the motor disorders. So we finished about anatomy, histology, and about the diverticulums and anomalies that can cause, and now we are coming to the muscular disorders. Now, why muscular disorders of the esophagus are important is because the whatever food we eat, it is going inside of the stomach because of the peristaltic movements or the propulsive coordination by the nerves and the muscles. So if that doesn't happen, the food can be stuck at various places. So because of that, there will be dysphagia. All right, and then whenever there is more ingested food placed at different points at different levels, that will cause inflammation again of the esophageal mucosa. So that's the reason we have to know about the muscular disorders. So now The muscular disorders can be the upper esophageal dysphagia and the lower esophageal dysphagia. I've already told you in the histology, the upper 2/3 of the esophagus are lined by the inner stratified muscle. Okay, the muscle is stratified there, and then here striated. I mean, there is a striated muscle, and then with the stratified squamous epithelium in the upper 2/3 and the lower esophageal, that is the lower 1/3 is usually having the smooth muscle. So what are the examples here? Dermatomyositis, myasthenia gravis, and the stroke can lead to the upper esophageal dysphagia, and the lower esophageal dysphagia is a smooth muscle dysmotility, which can be caused by systemic sclerosis, Entrez syndrome, and achalasia. Now, what is the functional obstruction? I told you there is coordinated contraction, right? So muscular dysfunction can also be seen in these lesions, that is achalasia, hiatus hernia, esophageal diverticular webs, and rings. We will go into detail about each one now. So what is achalasia? Achalasia, you have to remember a triad, that is incomplete relaxation of the lower esophageal sphincter and increased tone of the lower esophageal sphincter and aperistalsis. So the food, if it has to go inside, there should be a little pressure difference created between the stomach and the esophagus. That is done by the lower esophageal sphincter. That is a functional thing, right? So the lower esophageal sphincter, if it is too much contracted, whatever food you're eating, it just gets stuck, and then you can't actually make the food go into the stomach. So that's what happens here. There is complete relaxation of the lower esophageal sphincter with increased tone, that is increased contraction of the sphincter, and obviously there is no peristalsis or no coordinated movement. So this happens when there is absent ganglion cells. You know, the nerve is the one which sends a signal to coordinate, right? That doesn't happen here. So decreases proximal smooth muscle contraction and loss of VIP, that is one of the thing which relaxes the lower esophageal sphincter. Then coming to the the acquired cause is a Chagas disease, wherein the destruction is by the leishmanial forms. So you know there is some nerve muscle dysfunction here that is caused because of the leishmania here in Chagas disease. So in the barium swallow of achalasia, you find the bird beak appearance. So remember this, the bird beak appearance is very common question in your PhD entrance exam. So clinical findings, what you find is that there is nocturnal regurgitation of undigested food, and then there is aperistatic esophagus. You always find that there's something inside your esophagus, and then abnormal esophageal manometry, which detects the aperistalsis and failure of LES relaxation. Now, this is an example where this is diaphragmatic hiatus, if you remember, and it's the fundus of the stomach, and the esophagus is lower esophageal sphincter here is too much contracted, so the food what we eat will not reach the stomach, right? And the other one is SCAD, these rings and webs. Also, these things are a little bit uncommon, but you just have to know that these rings are also present, which can obstruct or which can create discoordinated movement between the muscle and the nerves. Now, what is advanced achalasia? It's just a gross picture to show this esophagus cut section. Then you can see this area where in this very constricted area of the lower esophageal sphincter, right? And there's something else called Plummer-Vinson syndrome. This is due to chronic iron deficiency. It is also called as Patterson-Kelly syndrome. There will be mucus lesions of the oral mucosa and the esophagus. There are esophageal webs and the iron deficiency. This is a triad which you have to remember. And because of that, there will be intermediate dysphagia because there's an esophageal web. Web is nothing but it's just a outpouching of the esophageal mucosa or a stricture that we have. Right now, coming to the hiatal hernia. Hiatal hernia is nothing but it has three types of hernia, that is sliding hernia, esophageal hernia, and pleuroperitoneal diaphragmatic hernia. Now we'll look into sliding hernia. This is the most common type when the proximal stomach will be going up into the esophagus through a widened diaphragmatic hiatus. So what happens then? There can be heartburn, and hematemesis, ulceration, and stricture. Now, paraesophageal hernia is a portion alongside, so there is a esophagus, and then the stomach doesn't go into the esophagus like that of the sliding hernia, but it is coming adjacent to the esophagus. That is about the paraesophageal hernia. Now, pleuroperitoneal diaphragmatic hernia, which is otherwise called as Bogdell-like hernia, which is present early in the life. So what happens here? The visceral contents extend through the posterolateral part of the diaphragm on the left into the chest cavity. So there's this part is coming out and going into the chest cavity, so that there will be some part of respiratory distress. So the loops of bowel are present in the left pleural cavity on the X-ray. That's what you can find here. So this is an example of the sliding hernia. So you can see this is the stomach which is going inside. The part of the esophagus is the most common type. And then here you can see the paraesophageal hernia, wherein the part of the stomach is protruding parallel to the lower end of the esophagus. So this is the paraesophageal hernia. Now, we have to mourn, I think, a little bit regarding the Swigians and the Zomatians because of the lockdown and COVID. I don't think people are eating outside anymore, and then there is no gastroesophageal reflux disease because at the house you eat at regular intervals, right? So the gastroesophageal reflux disease, as a name suggests, is the reflux of the acid and the contents of the stomach back into the esophagus. So what are the risk factors? The smoking, alcohol, caffeine, fatty foods, chocolate, and hyperhernia. So many of you must have experienced what are the risk factors, right? Now coming to the pathogenesis, there is transient relaxation of the lower esophageal sphincter. So in achalasia, what happens? There is more constriction, so that the food which is reaching the lower end of the esophagus doesn't allow it to go into the stomach. Here what is happening is that there is total relaxation of the lower esophageal sphincter. So there is reflux of acid and bile into the distal esophagus, right? So there is if you remember, I've already told you why the concepts are important. The constrictions, the upper, the cricopharyngeus, if that is weakened, there will be a pulsation outside and that will cause a zygus diverticulum or the web, right? If the lower esophageal sphincter, there's a functional sphincter that is weakened, then what happens? The food regurgitates, right? So this is the importance of anatomy and physiology you have to know, right? So there is reflux of acid and bile into the distal esophagus, ineffective esophageal clearance of the reflux material. So what do you find? What complaints will the patient tell you when they come with this? So the clinical find is a non-cardiac chest pain. Usually the elderly, they take soda and all for proper digestion. They say that something is wrong with the chest. You know, many elderly women, they just go and take an ECG to rule out any kind of chest pain. You know, sometimes that happens. So you have to know there's a non-cardiac chest pain, nocturnal cough, nocturnal asthma, and heartburn, acid injury, and Barrett's esophagus. See, Barrett's esophagus occurs with prolonged gastroesophageal reflux disease. Now, what are the predisposing factors for a reflux to happen? So, sliding hiatus hernia, obviously, stomach, part of the stomach is out of the diaphragmatic hiatus and going up into the esophagus. So, definitely sliding hiatus hernia is one. Enteronic gastric and urinary ulcers, surgical vagotomy. See, the vagus nerve that travels right and left to the esophagus and from the esophageal plexus and supplies it. If that neural damage is there, then it is a predisposing factor because you're not having any nerve muscle coordination. So neuropathy in alcoholics, diabetics, and esophagogastrostomy, it is combining both, right? So endoscopic shows loss of demarcation of squamo-columnar junction. So what happens, obviously, that the esophagus is lined by the stratified squamous epithelium, and then the columnar, the fundus mucosa is present, right? And that is a junction. I already told you about the junction and mucosa. Now, microscopy of the distal esophagus shows basal cell hyperplasia and elongation of papillae touching the surface epithelium. See, usually in the stratified squamous epithelium, any epithelium for that sense in the body has to rejuvenate. You know, in winter, you have this dry skin and then that falls off and then rejuvenates. So there is a natural healing process that occurs. So what causes this is that the basal layer of the skin epithelium will have the potency to produce more skin cells. So by proliferation. So because there is esophagitis or inflammation, what is happening is that there is basal cell hyperplasia. That means it wants to be strong. It wants to make the epithelium strong and fight all the acid which is coming out. So to increase that tensile strength, it tries to proliferate and make more squamous cells. And then elongation of papillae touching the surface epithelium, right? Now, after knowing about a little bit about the gastroesophageal reflux disease and what it causes, we are coming to a totally different thing, that is the tears which can happen in the esophagus by trauma or alcohol or anything. So this syndrome is called as Malarious syndrome, where the mucosal tear in the proximal stomach and the distal esophagus. It is due to severe retching in alcoholics or bulimia. What is bulimia? It's like bulimia nervosa is like you continuously eat and then binge, like, you know. So which causes hematemesis. A lot of, obviously there's a mucosal tear and then you cough out blood. Now, another one is a Boerhaave syndrome, where it's a rupture of the distal esophagus and the cause of the endoscopy. So that's the reason why when you know that you're going to the constriction areas and all, you have to know where, what. So when you are putting a gastrostomy tube, you should not puncture the mucosa or already formed stricture or already formed ulcer, right? So there is a retching, there can be retching, and then bulimia. That can be the causes of the rupture in Boerhaave syndrome. Now, what complications it can occur? Pneumomediastinum, because the air, once you're tearing some mucosa, the air can come into the mediastinum and then produces a crunching sound. This is called as Hammond's crunch on physical examination. That gives a clue that there's a tear, right? So pleural effusion that contains food, acid, and mucus. So we have known about 4 syndromes now: Vetter syndrome, Plummer-Vincer syndrome, then Malarious, tears, and Boerhaave syndrome, right? You have to remember all these syndromes. This can be given as a multiple choice question for you. So before I move on to another lesion, just again, repetition of what I told you: the stratified squamous epithelium lines the lumen of the esophagus, and then the lamina propria, and then muscularis propria. Here you can see the submucosa and the submucosal glands, inner circular muscle layer, and the outer longitudinal layer, and the adventitia. So what I want to stress upon is the stratified squamous epithelium here, right? So the Barrett's esophagus is defined as the replacement of the stratified squamous epithelium by the intestinal mucosa. I'm not calling it as just columnar metaplasia. I'm calling it as an intestinal mucosa because we have to demonstrate the goblet cells in the esophagus to call it as Barrett's, because there can be heterotopia or an ectopic tissue while there is congenital formation. What is heterotopia? Misplacement of the tissue. So that can happen when there is Barrett's esophagus. So what are the predisposing factors? The predisposing factors are the elder age, gastroesophageal reflux disease, and there can be a pre-malignant condition. That is, this Barrett's esophagus is a pre-malignant condition, and that may lead to dysplasia, carcinoma in situ, and esophageal adenocarcinoma. So what is Barrett's? It's not just columnar metaplasia, but it's a goblet cells which we have to demonstrate because of the difference between the heterotopia or an ectopic tissue which can be misplaced during the congenital or formation, right? So you know that the formation, how it happens. So now this is the squamous and the columnar, this is a squamous, and you can see the columnar metaplasia here happening. This is the columnar, and these are the goblet cells, right? So what you can see is that there is metaplasia, that is one tissue. What is metaplasia? It is one tissue forming into the other differentiated tissue, right? So that's what happens here. So the stratified squamous epithelium replaced by the columnar epithelium, that is intestinal type of epithelium. Okay, so there can occur, the dysplasia can occur anywhere, but it starts with a little bit of this. So this is a gross section, gross appearance of the esophagus with the tongues of the epithelium with the columnar metaplasia extending. These are the tongues of the tissue, which you can see here. This gives an evidence that there can be Barrett's, right? So this is the columnar metaplasia, what you are seeing here. This is the columnar, the goblet cells, which is typical of the intestinal epithelium, you can see here. So that is about the Barrett's esophagus. So here you are seeing dysplastic areas in the columnar epithelium of the metaplastic squamous epithelium, which led to the columnar goblet cells here, and then you can see little dysplasia in this glands, right? So this, so just for you, you have to know that Barrett's esophagus can occur in a prolonged gastroesophageal reflux disease, and the Barrett's esophagus can now lead to something more, that is dysplasia, and then something else, that is also the in situ. So this happens just not in one day, right? So the dietary factors, the lifestyle, smoking, everything adds on to this kind of formation of a carcinoma inside the esophagus. So what we are seeing here is a mucosal, intramucosal adenocarcinoma, which is, you can see a lot of dysplastic glands here, which are tiny, and then you can see a lot of dysplastic glands here, right? So after Barrett's esophagitis or esophagus, which can predispose to adenocarcinoma, I'm going to deal with infectious esophagitis. Esophagitis can be due to reflux, that's a reflex esophagitis. It can be chemical esophagitis, which is called as an chemical is nothing but corrosive agents or alkali, which can cause inflammation and loss of mucosa that can eventually cause ulcer, bleeding, hematomas. So there are other causes of esophagitis, that is infectious esophagitis, which is usually a complication of AIDS. What do you see there? The herpes simplex virus. See, these are all the opportunistic infections which can affect the person. So what can happen in AIDS person? That there can be HSV infection, which is denoted by the multinucleated squamous cells with intranuclear inclusions. And here you can see the cytomegalovirus, that is basophilic intranuclear inclusions. In Candida, usually demonstrated by yeast and pseudohyphae. There can be oral thrush in addition to the candidal esophagitis. So whenever you have a person with HIV, you have to keep all these opportunistic infections in your mind, right? So all these can cause adenophagia and dysphagia. So there's something called as eosinophilic esophagitis. It is different from any parasitic esophagitis or infectious esophagitis or GRD, because eosinophilic esophagitis is something like an allergic reaction. Okay, it almost resembles a trachea with transverse kind of things. You can see this kind of ring-like structures here. That is the eosinophilic esophagitis gross appearance. So once you put a gastrostomy tube, you'll never miss an eosinophilic esophagitis. So in the microscopy, you can see numerous eosinophils which are situated in the mucosa, right? So this is about the eosinophilic esophagitis. Now, coming to the venous supply of the esophagus. So I told you about the three parts of the esophagus: is cervical, abdominal, thoracic, and abdominal. The cervical part supplied by the inferior thyroid artery. When I'm talking about the blood supply, I told you. Then the thoracic part by the thoracic artery, and the abdominal part by the cleft gastric artery. So now you need to know about the venous supply of the esophagus, because that is how you learn from the concept to the pathology, right? So here you can see this There are some esophageal veins that get drained into the esophagus vein, the hemiesophagus vein, they go into the superior vena cava, and then this inferior thyroid veins which also drain out. And then here you can see the lower part of the esophagus that is given by the left gastric vein and the short gastric vein, so the coronary veins which anastomose with the portal vein. So there is an anastomosis between the portosystemic areas, right? So what is happening here is that whenever there is the portal vein, drains into the liver. So what happens is that if the liver is having cirrhosis or an alcoholic, having continuous drinking and all, what happens is that there will be fibrosis of the liver, and then because of that, there is backflow into the portal vein and then into the zygous vein. So because of that, what happens, there is formation of collaterals. So when there is formation of collaterals, that will lead to formation of varices. So just the basic, whenever there is a fibrosis, there is a backflow of the blood into the draining vein, and that vein will give it collaterals. Collateral is formation of new blood vessels. So you can't leave the organ like that. So the body's mechanism is to protect it by formation of collaterals. So this can be harmful as well, because there will be esophageal varices formation, and this esophageal varices may rupture and may cause hematemesis, right? So that's a medical emergency. So dilated submucosal left gastric coronary veins with complication of portal hypertension from cirrhosis, alcoholic abuse is most common cause. Just remember that. And then clinical findings, rupture with massive hematemesis is most common cause of death in cirrhosis. So I told you this is a medical emergency, the esophageal rupture, right? So this is the cross picture. You can see the esophagus. What you have to remember is that there is these varices, right? See here you can. So how would this varices look under the microscope? This is stratified squamous epithelium, and you can see long dilated blood vessels which are congested with the blood. So this is the typical finding of the esophageal varices, right? So now coming to the tumors of the esophagus. So you have to know that the tumors of the esophagus can be benign or malignant like any other organ, but benign tumors are very, very uncommon. They are less than 3 centimeters if it are present. There can be a squamous papilloma or an adenoma. And the malignant tumors are mostly the carcinomas, and usually sarcomas are rare. The carcinomas can be a squamous cell carcinoma or adenocarcinoma. They can be any uncommon type of carcinomas which can occur as well. The 5-year survival rate is 5 to 10%, and usually the adult males are affected. So what is the cause of a formation of a cancer? They told you gastroesophageal reflux disease causing esophagitis. There is inflammation of the esophageal mucosa. Repeated mucosa may lead to formation of Barrett's esophagus. There is transition from the columnar epithelium to from the squamous epithelium to the columnar epithelium or the goblet cells, and then there is diet in the person. Because of that, there can be a predisposition to the formation of carcinoma. So there can be diet, the person has esophageal disorders, the race, family history, genetic history, HPV infection, and P53 oncogene that can give rise to the tumors of the esophagus. Now, usually where the esophageal cancers can occur. So this upper third, usually 20%, and middle third is 50%. So usually the middle third is the most affected part in the esophagus. So these are the types of the lesions of the gross appearance of the tumor. This is a polypoid, and this can be an ulcerating type, and then diffuse infiltrating type. Right, so there's polypoid, ulcerating type, and diffuse infiltrating type. Now, I told you the most common cancers are the squamous cell carcinoma and the adenocarcinoma. Then squamous cell carcinoma occurs in 6 to 7 decades of life, and usually 4th, 5th. See, this statistics are a bit, because they say that in the books, they say that squamous cell carcinoma is most common, adenocarcinoma is less than 10%. It depends upon the region. In UK, it's usually the adenocarcinoma, which is more common than squamous cell carcinoma. So it's quite depends on the region. So more common in the middle and lower third of the esophagus, I already told you, it can be polypoid, ulcerating, and diffuse infiltrating. So adenocarcinomas occur in the lower third of the esophagus, and it is predisposed by the Barrett's esophagus. The recent advances 24 say that it is very, very low that the Barrett's esophagus go into the adenocarcinoma. However, they are screening the persons with GERD and the Barrett's esophagus like we do for a BART screening or a cervical carcinoma, like the same way they do screening for Barrett's esophagus people for checking the predisposition or the occurrence of adenocarcinoma and the grossly fibrous nodular elevated masses. Squamous cell carcinoma, they can be ranged from well to moderately differentiated. Usually, what you see is a recapitulation of the function of the squamous epithelium, that is production of keratin pearls, epithelial pearls, which are characteristic of that, and the other types of squamous cell carcinoma that can present, the verrucous squamous and exophytic slow growing and well differentiated. But just to know that squamous cell carcinoma, you identify it by the birth, right? So adenocarcinoma, there can be intestinal adenosquamous, adenoid cystic patterns can also be seen. I already told you that it's not like only these tumors can occur in the esophagus. There are many uncommon lesions that can occur with this mucoepidermoid, malignant melanoma, old cell carcinoma, undifferentiated carcinoma, carcinosarcoma, and secondary tumors. So, how the gross appearance squamous cell carcinoma looks like. Here you can see this mass different from the mucosa here, right? So, this is the mass which represents the growth of the esophagus, okay? And here it can be endophytic or exophytic. Endophytic is that it can go into the lumen, or exophytic outside of the lumen, and then there can be infiltrating, which can be just the plane of the wall. They can be just grow through the plane of the wall. It can be just like a thickening. You put 2 papers together, 3 papers together. It's just thickening of the wall. Finally, you know that it is carcinoma when you do a cross examination in microscopy. So bulky polypoid tumors tend to obstruct early. So what can be the clinical feature? Obviously, there will be obstruction, dysphagia, and chest pain, right? So they are likely to bleed, okay? And there can be a circumferential compression. Obviously, there's a growth and then it compresses. So the local extension into the mediastinal structure is a common and major problem. Obviously, usually the mediastinal nodes drain the middle third, and if you remember the lymphatic drainage, the upper third goes in cervical nodes, and the mediastinal nodes also there is a lymphatic drainage. So that can lead to mediastinal lymph nodes and then metastasis into that. So neoplastic squamous cells have the epithelial pearls, and then some population have predominant spindle cell population of tumor. Okay. So coming to the adenocarcinoma, you can see this exophytic growth here. This is the tumor area, which you can see here. Okay. Then I told you this is most common in the United States than squamous cell carcinoma. And then you can see the Barrett's esophagus being the predisposition, and men are commonly affected. And then what is the reason behind the molecular genetics behind the formation of this is inactivation of the INK4A, CDKN, tumor suppressor gene, and P16. Inactivation of the INK4A, CDKN, and tumor suppressor gene P16. Right? Remember these things. Other features include the P53 loss, inactivation of the tumor suppressor gene, that is the RB gene, and amplification of cell cycle related genes. So just have to remember these genes. There is a proto-oncogene and tumor suppressor gene. If you remember, the tumor formation is suppressed by the tumor suppressor gene. So inactivation of the tumor suppressor gene will activate the growth of the cancer. So the endoscopic surveillance is also being taken place. So now coming to the summary of what all I have taught you, just a brief thing. The achalasia and hiatus hernia are the muscular dysfunction of the esophagus. Already told you there can be upper motor disorders and the lower motor disorders. And then you have to remember Barrett's esophagus, very, very important, with the intestinal metaplasia or the squamous epithelium being the pre-malignant condition to the adenocarcinoma. The common cancer is the squamous cell carcinoma, affecting middle third of the esophagus. I know a person who has been a continuous smoker all through his life, and then he got squamous cell carcinoma, which was like very short, did not involve the lower layers also, but they have operated him, and then the patient died with pulmonary edema because he aspirated the thing during the surgery. So these things are very common during surgeries of the carcinomas. Then the overall summary, the esophagus is a long, hollow muscular tube that extends from the oropharynx to the fundus of the stomach, passes through the diaphragmatic hiatus, and then there are some constrictions here. There is a precopharyngeal constriction, the tracheal bifurcation, and the lower esophageal sphincter. These are anatomic constrictions, and this is the physiological constrictions are two. One, that is the LES, and the upper esophageal, that is the precopharyngeal level. And then you know that if the formation of the esophagus happens with about 7 weeks of gestation, both the trachea and the esophagus are separated. If they don't separate, they form a tracheoesophageal fistula. There can be associated with atresia, that is a thin non-canalized tube, and then there can be a genesis, duplication, and then there can be diverticulum. You know, you have to know about the tracheoesophageal fistula, and then the diverticulum, that is the outpouching where there is weakness of the muscle, right? So this is Zenker's diverticulum, retraction diverticulum. Okay, then we talked about the muscular disorders of the various types of hernia, the sliding hernia, the paraesophageal hernia, and then pleuroperitoneal hernia, right? Then we talked about the various strictures and the foreign bodies that can be impacted at the various anatomical constrictions. Then we also talked about the reflex esophagitis. We talked about a lot of esophagitis, that's chemical esophagitis, infectious esophagitis, which you have to remember mostly in the AIDS patient, and eosinophilic esophagitis, which is allergic. You know, rings are the most common thing. And then reflex esophagitis, wherein the acid comes back into the esophagus, then will cause the repeated thing may cause heartburn. The patient complains of the heartburn, and then that prolonged reflex esophagitis may lead to Barrett's esophagus. Then Barrett's esophagus may lead to the adenocarcinoma in situ, and then the adenocarcinoma which can go and extend and kill a man's life, right? So there are some other tears which we talked about, the Mallory-Weiss syndrome, that is caused by the severe tear that can happen because of the alcohol, and we spoke about the Burr-Harris syndrome. Then we spoke about the Plummer-Vinson and Patty-Carrison syndrome, which is iron deficiency in the esophageal web, and the oral and mucosal lesion. So all these things are very, very important for you to know. So just remember, esophagus, you have to know about the concepts where you should be aware of the venous supply and the esophageal variceal formation. I told you the esophageal variceal formation is a medical emergency, because remember the anatomy, physiology, and why there is the pathology. Then things become easier for you, right? Thank you for listening to my class with a lot of patience. I think the class can be utilized if you make some notes of the summary, and then you turn it out. If you have any doubt, you can come and ask me in the next class. Tomorrow I'm going to give you a few questions regarding what I have told you today, and then I will also tell you about the stomach, right? So this is about the esophagus and the tumors, the congenital lesions, and the motor disorders, finally, chapter on the esophagus. So just don't think that this is a replacement of what you can learn from the textbook. So just go through your text and then, find the missing links. Join all that, right? All that. All right. Fine. Thank you.